My presentation is based on a paper that we wrote and was published in MedEd Portal May 6, 2022, with my team of medical students and pre-medical students, including soon-to-be Dr. Tanani, who I'm very fortunate to be my mentee. And in some ways follow her lead on many of these issues. These are my disclosures. So, I run a disability rights advocacy organization. I have a physical disability, and I'm a white guy with physical disability and power. So watch out, and I'm very inspirational. Right? I really hate it. This is the outline of my talk. So just to give you a little idea of who I am and where I've been, this is me in 2002, riding a bike up the hill in San Francisco, extremely fit and ableist, and having no idea about disability, no training, just really the only experiences I had with disability were patients who were admitted to the hospital from the nursing home with urinary tract infections or decubitus ulcers, so I had just seen only the worst part of it. Unfortunately, I had a bicycle accident on January 5th, 2003. This is me in the hospital in the ICU, getting care where I had been a doctor myself just a few weeks before. And after a stay in the ICU, I was transferred to a rehab hospital. This is me with a wheelchair, driving a wheelchair with a joystick there, with my chin. I'm smiling very wide because I have a cookie bouquet, but was really not very happy about the situation. They told me to hope for the best, but prepare for the worst, and so that's what we did. And luckily, over time, I was able to regain some function, and this is how I roll around today, either walking with forearm crutches or on my Segway. And I didn't, luckily, being in the Bay Area, physicians with a couple of physicians with disabilities came to my hospital room to visit me, including Doug Olta from the Palo Alto VA. And so I did understand, and I was encouraged that I would be able to return to practice medicine, but I wouldn't end up in a nursing home, but I wouldn't be abandoned by my family and friends. And I also had, around that time, you guys may remember the show ER, there was this very strong-willed character, Dr. Weaver, who walked around with a forearm crutch. So I thought about her, and I still think about her, and what a badass she was, and I attempt to be one also, my job. So my Stanford radiology experience was characterized by open-mindedness of my program director, flexibility, understanding what we could and could not get away with, and constructing win-wins like my pre-medical volunteer program where these students come and shadow me, but also provide physical assistance. And I'd be remiss if I didn't mention my residency colleagues who have helped get me to this place. So I finished my fellowship in body imaging in 2009 and joined the faculty at Stanford, and was just working on building my career in radiology. And then about 10 years later, I stepped down from some of my education roles and began to look around at diversity initiatives around campus and realized that there's really a dearth of representation of disability in these diversity efforts. And so, having been involved in a subcommittee of the Faculty Senate on diversity, I sheepishly proposed that we work on a disability project in 2018. And of course, as the disabled person, I was put in charge of the project. I knew nothing about disability at Stanford or in the broader world. And I'd only had sort of one-off interactions with other medical professionals with disabilities. Usually you found me on the internet and wanted to just ask me questions. So this sort of organized advocacy was definitely not in my wheelhouse. So I founded what at that time I called the Stanford Medicine Abilities Coalition, not realizing that we don't like euphemisms like abilities instead of disabilities, and that's why we eventually changed our name to SMADIE. But very fortunate to have a lot of support at Stanford. The dean of the medical school is back there in the background in my chair. We've had like funding, acceptance, and I've had representation at high levels in the medical school. So props to Stanford also. So this is what we're focused on at SMADIE: health equity for patients with disabilities and disability inclusion for providers with disabilities and medical students, and basically everyone. We're also the employee resource group at Stanford Medicine, so we represent people with disabilities from the CEO on down to the front lines. This is our vision. I won't share our entire website with you, but we endeavor to transform the culture of Stanford Medicine and beyond from one of compliance, which is what we see too frequently, to proactive anti-ableism, where patients, employees, and trainees with all abilities can thrive. It's important to name your enemy, and that enemy is ableism. This is what we do: research, advocacy, community, education, health equity, and mentorship. I'm going to skip some of this, but medical school curricula has not traditionally included training on caring for patients with disabilities. And although this is changing, this is the majority, I think, of places don't have training specific to disabilities. There are a few medical students and residents and practicing physicians who identify as disabled. We often are discriminated against. People are very poorly trained on ableism, and diversity efforts often exclude disability. This infographic on the bottom right is for the Stanford Radiology Diversity Initiatives. They had not one but two people with obvious physical disabilities, but of course, nobody on that committee actually had a disability, and so as is a theme of my career, I volunteered myself to be on that committee to make sure that nothing about us without us. So, a lot of ableism comes from cultural misunderstandings. Like I said, I only seen patients at their worst, not thriving out in the community. We have experienced micro and macro aggressions, decisions about accommodations, maybe influenced by the capability imperative and this myth of the superhero position. And of course, negative attitudes can also lead to withholding of accommodations, which usually focus on impairment. And then, of course, the healthcare and education systems are focused on efficiency above all. We have lack of enforceable accessibility standards for clinical spaces. The Bonnie's working hard on changing that. Our DSPs, unfortunately, lack resources and knowledge and staff to meet the needs of our students. People know nothing about disability rights, and of course, structural dynamics are inflexible. So we have made advances. I know a lot of people around the country are working on curricula and disability, things like history and culture, social versus medical model, disparities, and ableism. So this is a very welcome trend. So I'll talk about my little research project and curriculum we developed at Stanford to complement the existing materials that are out there. We created a case-based learning session on disability from both a patient perspective and a provider perspective. And this curriculum can be used by any level of trainee, any type of health professional, administrators, or educators. But the goal is to engage learners in critical thinking about their role as a provider or a student or a colleague and how ableism impacts them. It helps participants transition from being observers to allies and hopefully advocates and co-conspirators in our efforts to overturn institutional ableism. So there are these two modules: disability in the patient experience and disability in the provider experience. And these were performed first at our second annual Stanford Conference on Disability in Healthcare and Medicine. So the part one is we saw pre-reading, Part 2, which was optional, was an introductory presentation on disabilities. It's kind of like a disability 101 thing. It's something that is included in the downloadable curriculum, useful for people who are beginners on this topic. We have 5 minutes of case presentation. We have a case of a resident with a radiology resident with an immune deficiency who was denied accommodations to work from home. A real case that I wrote about, and another case of a woman with congenital physical disability who was pregnant, but the provider assumed that she wouldn't be able to be a parent and recommended an abortion, despite the fact that this was a desired pregnancy. So those were the cases and the papers. We had small group breakouts, and then we came back into a large group and reviewed the key points. And then afterwards administered this post-session survey. This is our conceptual framework. So these were designed to facilitate an understanding that would go beyond just definitions and include action items for disabled, ableist, cultural norms. And it really prompted participants to reflect on their own disability-related perceptions, deconstruct the structural and individual barriers for individuals with disabilities, and to develop a framework for improving clinician and patient clinical interactions. And we were asking participants to engage as part of the scenarios and to connect participants with the human reality of disability, to stimulate deeper thinking with the goal of creating active forms of support and inclusion for patients and colleagues with disabilities. So when you download the curriculum, this is what you get, as I discussed earlier. Our evaluation strategy was a bit last minute, which is why we only had a post-session survey at our second annual conference. But we presented it the week after at Building the Next Gen of Academic Physicians in Medical Education conference, which was for URM students, not for disability specific. But we had our act together for that one. We did a pre- and post-session survey and quantitative and qualitative data. The survey, this is a breakdown of our survey participants. So the majority, 38%, were physicians. Then we had med school faculty, researchers, med ed folks, other allied health professionals, and then trainees, students, and residents. And these are people who, so combined we had 171 participants, but these were the people who gave their demographic information. And the scores were positive, on a 1 to 5 Likert scale. We got good scores for being educational, contributing to growth, and was engaging and interactive. This is for the provider experience one. And we had similar results for the patient experience. And then we did our pre- and post-session data analysis. You can see that the ability to define disability and ableism went up from 2.8 to 3.6, which was p-value 0.09. But people felt more confident that they could discuss how ableism manifests itself, to identify barriers, gaps, and resources, and to generate potential solutions for addressing these gaps and how to effectively advocate for the disability community. And these are the themes from our qualitative analysis. People need empathic doctors who see them as a person rather than a diagnosis. We had some very insightful quotes. The bias of disabled people's abilities interferes with care. Disability is not inability. Medical programs should seek out ways to incorporate disability curriculum and disability education. Cultural humility is important. We need more people with disabilities leading these conversations and assisting with policy change. A culture shift is needed. So the onus has traditionally been on the individual to advocate for themselves and to be an expert in advocacy. And even then, there's, of course, pitfalls in the system, as was talked about earlier. this personal advocacy is exhausting on an individual level. So the culture change needs to happen from the top down. Attendees need to normalize training with a disability and advocate for a better system that they experience. And people said that so much of what I learned went beyond mere facts and entered the realm of strategy, knowing how to address which barriers I might face. So that's really what we're trying to accomplish with our conference, so much like beyond just presenting the facts and data, but trying to give people actual tools and strategies that they can take to their own institutions to advocate for change. And one of the most poignant quotes for me was that I feel less alone. I feel like I have at least one next step to advocate myself, and also better ideas on how to advocate. And this, I feel less alone, I think is so important. For me at Stanford, I have a community of folks who are proud to be disabled, lucky to have the support of the institution, even though I'm a professional irritant to them. They probably don't really like me, but oh well, I'm not there to be liked, I'm there to advocate for change. And so, there were, just as far as the discussion goes, we had some challenges. We wanted to develop objective language that wasn't biasing or overtly leading people, real life cases, so that people could really connect with the material. We had multiple metrics for these different conferences, which was not ideal. Bonnie would probably cringe at our methods of this paper. No pre-session survey data for a large percentage of these people. And then, of course, it was a limited scope of discussion, right? We only talked about a physical disability and an immune-compromised radiology resident, so it may not be applicable to a larger population. And then, of course, it was also presented at a conference focused on addressing ableism and disability advocacy, so that the audience was enriched with people who are predisposed to openness toward this topic. Although that other conference was not focused on disability, like I said earlier. And then, of course, we have no idea about the long-term retention of material. And so, it'd be really interesting to go back and survey these people and see how much they retain. And it would be really interesting to evaluate the effectiveness of these kinds of modules and settings, such as mandatory healthcare, training, and public awareness workshops. And future iterations can be used in the context of providing a guide and a resource within both healthcare and higher education. And so these are my references here. There are a lot of them in the paper. I would just say, I'm also sort of a professional cheerleader, and let's do it. People in this room are doing amazing work. We need to continue to publish and share and collaborate with each other. It's a small community, but it's a powerful community. And I think together, working across disabilities, across other underrepresented or minoritized groups, we can accomplish our goals. So with that, I'll say thank you. Open it up for questions.